to the last talk.
Okay, it's my pleasure to ask Konstantin Dobrenkov from the United States to give an overview on targeted therapies in neuroblastoma. So, enjoy.
Good morning, everyone. Thank you very much for coming, and especially thank you very much for staying until the last presentation, which is mine. And I would like to thank the organizing committee for giving me the opportunity to give this talk here at this fantastic meeting. So I'm going to talk about actionable targets in neuroblastoma. As you know, targeted therapy as a term really has become a buzzword in oncology world, including pediatric oncology. But from the clinical standpoint, there are at least two questions which come up here. The first one, in regard to targets, the first one, how specific are these targets? And the second and most important question, are these targets actionable or druggable? And neuroblastoma, from this point of view, represents one of the most interesting tumors. As you know, for adult oncology, neuroblastoma is orphan disease. It's only 600 to 700 new cases are diagnosed in the United States each year. But for us, for pediatric oncologists, definitely it's a very important entity because it's the most common tumor in infants and most common as a cranial solid tumor in whole childhood population. And we know that neuroblastoma contributes significantly to the cancer-related mortality in children. And despite the introduction of all these new agents, all these new therapies, unfortunately, about 1/3 of the patients with high-risk disease still have a very poor prognosis. So what we know from embryology, neuroblastoma is a derivative of neural crest, and some other tumors have the same origin here, and it makes it a very unique tumor in terms of targeted therapy. Neuroblastoma shares common pathways in neural crest, including MYC-N, ALK, and some others, and also it represents almost ideal target for immunotherapy since it expresses embryonic antigens like GD2-L1COM and some others. So the first and most crucial step in designing of new therapy is to define ideal targets. Here in this cartoon, it's very nicely represented the potential targets in neuroblastoma. Some of them are very well known, like GD2-L1COM, so extracellular compounds, and also ALK, along with the intracellular targets. And the central place here is taken by MYC-N, including downstream and upstream associated pathways. GD2 as a target, we know it's a very attractive, actionable target because it's constitutively expressed by neuroblastoma. It has very high density on tumor cells, and also, as I mentioned before, it's oncofetal antigen, so embryonic antigen, meaning that in postnatal period, its expression is highly restricted in normal tissues. And NCI ranked the GD2 antigen amongst more than 70 other antigens based on different parameters like immunogenicity, therapeutic function, and some others, ranked on place 12. And if we subtract non-actionable targets from this list, the rank for GD2 even higher. Here's a representation of the possible agents which can target GD2. First of all, it's of course anti-GD2 antibodies which exploit different mechanisms of cytotoxicity, including ADCC, complement-mediated cytotoxicity. Also the use of some more sophisticated agents like bispecific antibodies and CAR-modified T cells. This landmark study done by COG and published in 2010 showed the clear clinical benefit with use of anti-GD2 antibody in patients with neuroblastoma. Since then, it has become standard of care in neuroblastoma patients. And on the right panel, you can see the experience, more than 25-year experience from Memorial Sloan Kettering Cancer Center, showing the role of these antibodies in patients with high-risk disease and even ultra-high-risk disease. So definitely, both studies clearly demonstrated a very substantial clinical benefit of antibodies. And this is the most dramatic example of therapeutic efficacy of anti-IgG2 antibodies. The patients with CNS neuroblastoma, historically the median survival is less than 6 months in these patients. And introduction of anti-IgG2 and also another type of monoclonal antibodies, anti-BCL-H3, and coupling, labeling it with radioisotopes resulted in a tremendous increase in overall survival for these patients. More than 50 patients follow-up studies we have now. After more than 10 years follow-up, more than 50 patients survive without evidence of disease, and this treatment has a very low toxicity. And of course, there have been many attempts to improve the efficacy of antibodies, and based on the classical structure, IgG structure on the antibodies, many other agents have been created, including, as shown here, radiolabeled antibody, drug conjugates, immunocytokine conjugates, as well as already mentioned bispecific antibodies with various formats. And we also can use just a part of antibody, antigen-recognizing part of antibody, to engineer the new agents like bispecific antibodies. And there was a special session, a satellite symposium on blinatumomab, which showed tremendous results in acute leukemias. So some of such agents were created also for neuroblastoma, and definitely chimeric antigen receptor T cells. So this is a schematic representation of CAR design, chimeric antigen receptor design, when we take just a part, antigen-recognizing part, and fuse it to the activatory part of T cell receptor. So, but as we know, there are numerous trials that have been done by many groups and a large amount of patients. But so far, we have witnessed a very good therapeutic effect in CD19 positive leukemia. But this effect, this therapeutic efficacy, hasn't been reproduced in patients with solid tumors. And, there have been a couple of studies, including neuroblastoma, also GBM and mesothelioma, but the results of the studies are still very suboptimal. Here are listed some of the currently ongoing studies with GD2 CAR T cells, mostly in the United States. Different generation of CAR T cells and more sophisticated construct are being used now, and in Sloan Kettering just recently preclinical trials, preclinical studies showed a very high efficacy of so-called turbo CAR T cells, where the CAR T cells stimulate themselves and stimulate bystander cells by expressing costimulatory receptors. Definitely the work is being done and we are awaiting results, but again, still the results of CAR T cell therapy in neuroblastoma and other solid tumors is still suboptimal. This is a bispecific antibody construct which was developed by Dr. Nai-Kong Chang in Sloan Kettering. This is so-called modular format, where to the classical fork structure of IgG, two additional components are attached on the side. You can see them here. It's OKT, the CD3 recognizing domain. So these antibodies showed very high efficacy in very low concentration in preclinical studies. They can work in femtomolar, so 10 times to the minus 15 concentration. And their effect doesn't depend on the expression of checkpoint inhibitor, checkpoint markers like PD-1, PD-L1. So this particular antibody is entering clinical trials now. So, but what about GD2 has been very well characterized, and we are using it now in standard protocols. But what about other targets in neuroblastoma? This picture just shows several pathways implicated in the tumor genesis of this tumor, and again we see the central place, MYC MYC-N occupies a central place with associated pathways. There are some other potentially actionable targets here, like AKT, PI3K, CDKs, and some others. About 30 years ago, it was recognized that NMYC portends confers a dismal prognosis in patients in neuroblastoma. And since then, there have been many attempts to directly target MYC-N, especially given the fact that MYC-N expression is very restricted, and also MYC-N plays a central role in many pathways in tumorigenesis. So definitely it's very tempting to find an agent which could directly target MYC-N. So, and these attempts have been done. So RNA interference-induced knockdown of MYC-N showed very nice preclinical results, but technically this approach is very difficult to implement in clinic. Also, Omamic, it's an agent which blocks interaction between MYC-N and NEX, has just showed very modest anti-neuroblastoma activity, so they never entered clinical trials. So therefore, other agents have been tried exploiting MYC-N indirect targeting. And here we can talk about several groups of agents. So some of them interfere with MYC-N transcriptional activity. So-called bromodomain proteins, BRD2, BRD3, and 4, can be suppressed by small molecule inhibitors. A prototype is JQ1. It binds to bromodomain and disrupts back recruitment of chromatin, and the downstream effect is a downregulating of MYC expression. BET inhibitors are now in ongoing trials in adults in different adult cancer, but they are also potentially very promising agents for the use in pediatrics. Oncoetics OTX-015, oral BET inhibitor, already being tested in clinical trials. The major concern for this particular group of agents is a lack of specificity and possible off-target effects, so the toxicity profile may be not that favorable. So another group of indirect targeting agents, it's MYC protein destabilizers. So you can destabilize the MYC-N complex with some agents, and after that this complex degrades. So some inhibitors of so-called aurora kinase A have been tested in clinical trials, including alisertib, and the data were published. Phase 1 clinical study didn't show any objective response. And now it's being tested in combination with cytostatics, including irinotecan and temozolomide. Another possibly active agent are those which target the PI3K and TOR pathways, and several drugs have been already tested in early phase clinical trials, like temozolomide, rapamycin, iridofarolimus. We're still waiting efficacy results. They show their very favorable toxicity profile, but definitely what we need to know their clinical efficacy and response rate. ALK, it's a relatively new target, but it's also a very interesting target in neuroblastoma. We know that ALK mutation or amplification confers on also dismal prognosis in patients with neuroblastoma. And most studied drug in this group in crizotinib, phase 1-2 studies have been done, which showed minimal toxicity, but at the same time clinical efficacy was suboptimal. The result was very modest, with one complete remission in 11 patients studied. But the major problem with crizotinib, tumor sensitivity is mutation specific. And what we learned from the studies in adults, many patients develop resistance to crizotinib. Therefore, a new generation of ALK inhibitors have been developed, including alectinib, brigatinib, and some others. So the study, phase 1 study with alectinib, the results of the study were just published a few weeks ago, and they showed overall response rate of 32%, this complete response rate 23%, which is very promising results, and we are waiting the results of the late phase studies. University of Pennsylvania just recently presented a new ROS1 inhibitor, PF, this is numbers in the name of this drug. So it works in preclinical studies. This particular agent works in crizotinib-resistant neuroblastoma, and most probably it will enter clinical trials very soon. ATRX, it's a hallmark of the neuroblastoma in older patients and in patients with so-called chronic disease. We know this term was coined by Dr. Kushner from Sloan Kettering. Unfortunately, at this point, we don't have any agents which could target ATRX. In regard to other small molecules, targeted small molecules, I would like to mention MEK1 and MEK2 inhibitors. Retrospective studies in refractory neuroblastoma show that most of the tumors, relapsed tumors, had somatic mutations activating the MAPK pathway, and potentially MEK1 and MEK2 inhibitors can be efficient in this group of patients. Primary neuroblastoma carries in 33% of cases, but in 1/3 of cases carry a genomic aberration in G1 cell cycle regulatory genes. And now in the market we have several compounds which target CDKs, including palbociclib, which is a CDK4, CDK6 inhibitor, and this is another potential agent for treatment of neuroblastoma. Here you see some other drugs, including kinase inhibitors, which have been already through the phase 2 study, and angiogenesis inhibitors. Bevacizumab is being tested in NSKCC together in combination with irinotecan temozolomide, and shows some interesting results which will be reported at ASCO meeting next week. So, but the message I would like to convey with my presentation is the following. So now there is an understanding, mostly coming from the adult oncology, that a single agent therapy most probably wouldn't be that efficient. We know only a few examples when one drug was extremely efficient, like including TKIs in chronic myeloid leukemia, but in most cases we will need a combination of therapy. And now we are entering, and we have already entered the era of big data. And the problem is not to retrieve, to obtain this data. Using all the sophisticated methods, we have already accumulated a large amount of data. But the major question, how we can integrate this new data in our knowledge, and how we can to identify, using all this data, to identify rational drug combinations based on all these studies, including genomic studies. And I would like to mention two very important projects. One of them is NEPENTI. It's related directly to neuroblastoma. This abbreviation stands for Next Generation Personalized Neuroblastoma Therapy. So it just recently started in the United States. It's a phase 1b/2 clinical trials for patients with refractory relapsed neuroblastoma. In this study, all different various parameters of genomic studies will be integrated in order to identify the specific pattern and to choose the corresponding suitable combination of the drugs. And another project, it's done under the auspices of NCI. It's a target project, which stands for Therapeutically Applicable Research, to generate effective treatments. It's not neuroblastoma specific, it applies to many tumors in children. So this particular study used data from whole genome exome transcriptome sequencing, gene expression methylation, chromosome copy number analysis in order to guide the development of novel efficient agents for patients with high-risk disease. I would like to stop here, and I'll be happy to take questions. I don't think I don't have more time, I believe, but it's fine. It's last slide.
Thank you very much. Very nice nice presentation. I have one question. So, could you mention about the possible application of PD1, PD-L1 antibody against the high-risk neuroblastoma?
Thank you very much for this question. It's really PD-1 inhibitors and PD-L1 inhibitors really change the paradigm in adult oncology. If you open any oncology journal now, there are at least one article about the PD-1 inhibitors there, and they have been tested extensively in adult cancers. And there are only a few trials in pediatric oncology, including brain tumors, which is being done in Sloan Kettering and some other institutions. We don't know the results yet. It seems to be that they have a very favorable toxicity profile, and definitely we expect that the indications in pediatric populations will be expected, including neuroblastoma. How they look in adult cancers, it's mostly carcinoma, refractory, and advanced disease. The results are really amazing, and definitely it has a potential role in pediatric tumors. We know that neuroblastoma itself does express these receptors and can be a potential target.
Okay, thank you.
Yeah, thank you everybody, and thank you. I think we should close the session to be in time for the next session. I thank all the speakers in the audience, and I think it was very interesting, at least to me, and I hope you feel the same.